Friends, welcome to my workplace at Ranaghat, West Bengal, India. In this video, let us observe phacoemulsification of a soft cataract. You can see this is a cataract with grade 2 nuclear sclerosis, and in such cases, it is always easier to manage the nucleus if we pre-chop the nucleus into several pieces. After incisions and filling up the anterior chamber with visco, capsulorhexis is done with the help of uterata forceps. So the size of this rhexis is about 5 millimeter. When the size is like this, when the size of the rhexis is about 5 millimeter, it is not easy to prolapse the nucleus into the anterior chamber or tilt the nucleus, and we have to do it in another way. And the best thing is to pre-chop in this way. This is Mohanta's pre-chopper and this is the sustainer, and these two instruments very easily divides the nucleus into pieces. And we have got 4 pieces out of this. And now management of this nucleus has become so easy. After filling up the antechamber with visco, the handpiece goes into the anterior chamber. The phaco needle goes into the anterior chamber, and we try to find a gap between the pieces, and the pieces are easily comes at the center of the anterior chamber, and we can easily emulsify these nuclear pieces. And this is the last nuclear piece, and it comes so easily. Finally, the epinucleus is removed. And now, let us see if we can remove the cortex by the handpiece itself. The machine is in irrigation aspiration mode, and vacuum is 350 and flow rate is 35, and the cortex is being removed by the handpiece. We have to be very careful. We must not catch the posterior capsule, and if we happen to catch the posterior capsule, we must stop immediately, use reflux and release it. I am not encouraging the beginners to do this. This may be dangerous. This may look dangerous, but see, all the cortex, including a cell that was sticking to the posterior capsule, has been removed. And now I fill up the anterior chamber with visco. Capsular bag as well as the anterior chamber is filled up with visco. And this is a Tecnis 1 intraocular lens, and I am trying to implant this lens by Appasamy's cartridge. See how beautifully the lens goes, and the haptics are placed in this way. Then we close the cartridge. The wings of the cartridge is closed. It's a butterfly cartridge, and how smoothly the lens is going forward. By wound assistance, we can implant this lens by 2.8 millimeter wound, but I am going to enlarge it little bit, maybe by 0.1 or 0.2 millimeter. So maybe this is size of the wound is now 2.9 or 3 millimeter. And see how easily the lens goes in the capsular bag. And by the left hand instrument, the lens has been placed in the bag. dial the lens by the chopper itself. This is a very small Sinski hook like chopper. It is known as Mohanta's chopper. And now our job is to clean the visco that is there in the anterior chamber and in the capsular bag. First, irrigation of the anterior chamber, and then irrigation and aspiration for some time, and then I go behind the lens, irrigate and aspirate for some time, and now I am planning to use the bimanual irrigation aspiration. We can use the bimanual irrigation aspiration from the very beginning, but routinely I use Simcoe for few seconds, decrease the amount of visco in the anterior chamber and the capsular bag, and then I use irrigation and aspiration cannuli. Irrigation aspiration cannuli works very good if there is less amount of visco in the anterior chamber and in the capsular bag. We go behind the eye well, irrigate and aspirate for some time, and here it is, irrigation and aspiration together, and all the visco has come out. If we clean the visco, give quality time to remove the visco, then the chance of IOP rise because of retained visco will be minimized or eliminated, and the patient will be very comfortable. And now this side port is closed by corneal stromal hydration. And now a final lavage by the 26G Simcoe. I like to form the anterior chamber with Simcoe in this way. The Simcoe is placed in the tunnel, keep it for some seconds, and then come out. And most of the time, almost 99.5% time, the main wound doesn't require any hydration. The main thing is we have not stressed the main wound. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence.